So the way I will take through this talk is talk about a case scenario and the whole burden of MDR infections we have and what are the choices we have at this point of time. So when you look at the prevalence or occurrence of MDR infections, so this is the latest data we have. This is from Antimicrobial Resistance Surveillance and Research Network. So this is from ICMR, and this is 2019. They have released their data. So if you look at this data, it just takes you through the burden of sort of MDR infections that we have. So this is E. coli data. So if you see this in ICU, let's look only at the ICU because E. coli, we know we have ESBL E. coli coming from the community. And if you see the OPD itself is 35.6%, wards you have 27.6, and ICU you have 14.9. So overall, it's around 28. So that leads the list with regards to MDR infections. So this is the Klebsiella, that's the way it looks. So if you see very carefully, the Klebsiella burden is more in ICU, 22%, and it comes second to E. coli with overall sort of an occurrence rate. And this is Pseudomonas. So Pseudomonas comes in the third place, around 11.9. So here the key thing for all of us to note is Klebsiella is a problem in ICU. When you look at ICU sort of occurrence of MDR, I'm sure many of the doctors present here would agree that Klebsiella is becoming a problem. Initially, it used to be Acinetobacter, we had a problem. So nowadays, it's more of Klebsiella. So then you get gram positive. So then you have Staphylococcus aureus sitting at 5.9% in ICU, overall 11.4. This is Enterococcus faecalis and Enterococcus faecium. So this is the layout of any of the resistant bugs that we deal with in ICU, or gram negative, followed by gram positive, and in gram negative, we all know it's E. coli, UTIs are the more common, followed by Klebsiella. But in ICU, it's more Klebsiella, which is a problem. And again, that same sort of a group, Antimicrobial Research Surveillance Network in 2019, has shown there has been a sequential rise in the Klebsiella from 13.9% in 2016 to 17.5% in 2019. And this ICMR has also looked into the susceptibility pattern. So what has been consistently shown is the susceptibility is around 50% to meropenem. So which means we have problem with resistance to carbapenem. So I'm sure all of you would be hearing about CRE, which is carbapenem is resistant enterobacteria. So that is where Klebsiella comes. So 50% are resistant to meropenem. But colistin, it tends to retain sensitivity. 93.5% are susceptible. But there are other data that comes from sort of individual tertiary care where they show a higher resistance to colistin as well. So when you look at this sort of a data, just look at the last sort of a column. So the amikacin resistance is around 50.1% for Klebsiella pneumonia. This is only the Klebsiella pneumonia data. But the colistin sensitivity is around 93.5% sensitivity. So 50.1 is the sensitive to amikacin. Otherwise, half of them are resistant. But if you look at the last three rows in the last column, so only about 50% of them are sensitive to carbapenems, which is akin to the previous sort of statistics that we showed, that 50% are resistant to carbapenems. So that's what this slide shows. So, and when you talk about cephalosporins, there is absolutely no hope because from 2008 to 2013, there has been a sequential sort of increase in the resistance to all the third generation cephalosporins. And some of the centers do claim colistin resistance to be sitting at 87.5%. So that is in only certain specified centers. Otherwise, as per the ICMR data, 93.5% are still susceptible Klebsiella, but carbapenem around 50% only are susceptible. And the PDR Pseudomonas also is increasing. So this is one study that came in 2016. Again, to re-emphasize, and this is two, as you see, the orange one is from Gandra et al. And they compared with the ICMR data of 2015. If you see the resistance, so Pseudomonas and Klebsiella, it is sitting at around 56. So ballpark figure of resistance to carbapenems is around more than 50% for Klebsiella. And this is Acinetobacter, where you have the resistance sitting at 70.9%. And they are comparable. So from Gandra study and the ICMR study. So basically all these to emphasize that carbapenem resistance is significantly increasing to most of these enterobacteria or escape organisms, whatever you want to call it. So this is a good sort of a study, which data which came out comparing globally the sort of resistant patterns. So when you look at carbapenem resistant Kleb pneumonia, you see Asia, you have more than 50% of them are resistant. So we have a problem. So the problem lies within Asia and more so in India, where if any Klebsiella you get in culture, you have to keep in mind that 50% of them would be resistant to carbapenems. And if you look at E. coli, it is much lesser, 13% as compared to other Western countries. And colistin resistant, which is of relevance to us because obviously when they are CRE bugs, which is carbapenem resistant enterobacteria, then the choices are very limited. Then you have to use colistin, polymyxin, or any other newer antibiotic. So colistin resistance club pneumonia is around 3 to 12%, and that's what we said. So 93% still retain some susceptibility to colistin. So the carbapenem resistance is increasing from 65 to 85%. And this is again the same statistics where increasing sort of a resistance is shown. So we'll just start with a case study because this talk was meant to take you through the case and to highlight the way how the patients evolve and the type of antibiotic choices that we would be using. So you can just look at 55-year-old, any sort of a female with diabetes, COPD, and coronary artery disease, who's had recurrent hospital admissions for COPD. Comes with acute sort of breath and fever. So in ER gets worsened, puts on NIV, and then gets intubated. And that's the X-ray that shows. So then the question automatically that comes to all of us is what would we do? Whether you would administer antibiotics, whether you would send blood cultures, or you would assess risk factors. I'm sure the answer is you would do all this in tandem. You would send blood cultures, you would give antibiotics, and you would obviously. So the point that we are trying to highlight is this becomes very important. The third point, assessing risk factors for MDR, because this is a patient who has been in and out of hospital with recurrent admissions and then now comes with a onset of fever. So the point to be emphasized is to understand the importance of local epidemiology in determining the choice of antibiotics. Not only antibiotics, because all this while all of us keep reiterating that, okay, antibiotics, we need to know local epidemiology. But now we have moved away from treatment aspect to diagnostic aspect. So we need to know local epidemiology to determine whether this blood culture is enough at all. So we have moved beyond that. We cannot stop at blood culture. We need now molecular diagnostics to determine the resistance very soon so that the appropriateness of antibiotics, if it is MDR organisms, if it is CRE, because even if you put carbapenem for this and if you are dealing with carbapenem resistant enterobacteria, then obviously we have not put him or her on antibiotics. So knowing the resistance patterns within your hospital has become more terribly important than the choice of antibiotics. So this patient anyway gets put on meropenem and vancomycin because she's had multiple admissions in the recent past. So day 5 in ICU, so she develops new fever and hypoxemia, and then she develops a lot of lung infiltrates bilaterally, and BAL culture is sent. Okay. So again, the reason for this narrative is not to ask what antibiotic you will start or what is the sort of thing that this is only to highlight the importance of diagnostic tools that we need to adopt in such patients to try to ascertain what sort of resistant bugs that we have within our hospital or ICU, and then customize your antibiotic and be very precise with the choice of antibiotic. So that is the intent of showing that case. So we have moved from conventional blood cultures to adopting multiplex PCR or advanced sort of a techniques to identify resistant bugs. Because the conventional blood cultures, it takes time, because even for that patient, we send blood culture, it would take at least 48 hours to get a bug. And some of the organisms do not grow if someone is already given an antibiotic. And we need to identify, we need to have tests to identify all different organisms, including Candida. And most importantly, now in this day and age, we need to understand what is the sort of drug resistance that is prevailing in these organisms. And we need to have tests that have reduced turnaround time, increased sensitivity. And this is very important in this day and age, because I need to know, suppose you know that your ICU has high carbapenem resistant organisms, because we know if you get Klebsiella, 50% are carbapenem. Would you use colistin? Because colistin or polymyxin, because if the gene test I do, I get MCR1 gene positive, then I know there will be colistin resistant also. So I cannot use that. So that's why it's become very imperative to adopt newer diagnostic tests and then optimize appropriate antibiotics. And all this will reduce the cost to the patient. And by using inappropriate antibiotics, what we would be doing is to induce resistance. So obviously we are duty bound to reduce the resistance patterns. And together, our intent is to reduce mortality. So this is the whole reason that we need to adopt molecular diagnostics in our armamentarium. Maybe around 5 to 8 years back, we were not emphasizing too much on molecular diagnostics. But in this day and age, we cannot sort of complete our workup without adopting molecular diagnostics for many of such patients. So this is just a brief overview of the sort of tests that are available to identify the resistance patterns and the genes associated. So just focus on the first column, which is turnaround time. That is what is important. And focus on the third column, which is the cause. So agglutinin assay, turnaround time is less than 5 minutes. So fish is fluorescent in situ hybridization. Turnaround time is 1 to 2 hours. And as you see, the cost for reagent is very less, and you don't need too much of skills to do this. RT-PCR is most popular, most widely available, and I'm sure many of you here present may be using in some form or the other. As you see, turnaround time is only 4 to 6 hours, but the reagents are a little expensive. That's why you would see when you order a multiplex PCR, we do get patients to spend a little bit of money for doing this test. And the efficiency is dependent on the systems that are adopted. So, LAMP assay is a loop-assisted isothermal amplification test. And as you see, turnaround time is less than 1 hour, but the reagents are expensive. I'm sure many of you have heard of NGS, because during COVID, some of the labs needed to have this NGS to identify whether it was an Omicron variant or whether it was a Delta variant or Beta. So now we are moving from RT-PCR to NGS, next generation sequencing. And as you see, it's very expensive. That's why we have very few labs that came during COVID, which were doing next generation sequencing. And you need a very high skill levels to interpret the genetic sort of determinants. MALDI-TOF is available in few places. I hear Narayana has MALDI-TOF. So, which is matrix assisted laser desorption time of flight. And as you see, turnaround time is less than 5 minutes, and the reagents are very cheap and the skill levels is high. So these are the sort of tests currently available to identify all the genes that are responsible for causing resistance. And now there is a new technique that has come, which is called nanopore technology. Currently, as I'm speaking, there is one that has come to Bangalore. So you will start soon hearing that people will start doing nanopore technology also to identify all the genes. Okay. So that's a brief overview of the sort of tests that you could adopt to identify the resistance patterns in these patients. So we'll go back to this case. So this patient grows Klebsiella pneumonia in the blood culture. And typically, as you see, it is resistant to most of the bugs. And susceptibility is there to colistin, because we saw the data that 93% retain the sensitivity to colistin, and it was sensitive to fosfomycin. And the genetic test or the molecular diagnostic shows OXA48 sort of an enzyme production with a gene coding for that. And the sensitivity done using disc diffusion. So for many of the doctors here, disc diffusion, so the bigger you see, the better it is with regards to sensitivity. So you see more space, so the inhibitory zone is better. So it shows sensitivity to this Ceftazidime-Avibactam. So the reason for showing this is how important it is to understand that this is the gene that is coding for OXA48 enzyme. Then we need to understand what is OXA48, and these are the names that every intensivist or a clinician should be aware what this means. What does OXA48 means? And we should have some inkling about what these enzymes are and what are the genes that code for this. So first, this OXA48 is a sort of an enzyme, which is a carbapenemase enzyme, which will deactivate carbapenems. This was first identified from Turkey in 2001 from Klebsiella, where 39 patients were found to have producing this OXA48 enzyme in 2006 to 7. Later, it spread to all these Middle Eastern countries, Libya, Egypt, and Lebanon, Egypt, and Belgium in 2010. In India, OXA181 was identified in 2006 and 7. After that, I think 11 enzyme variants have been identified. So these are all the enzymes which are produced to deactivate the carbapenems, and like how you have beta-lactamase sort of an enzymes. So these are the carbapenemase producing enzymes which are coded by a gene, and these are the names that are given. So as you see, there are 11 enzyme variants that are identified so far. But in India, the one which has been found to be very common is OXA48. That's why you keep hearing. And OXA48 is found to be very commonly produced by Klebsiella and E. coli. And anyone who has these resistant genes which are coding for this enzyme production, these patients have been found to have high mortality because of various reasons, because of the limited choice of antibiotics. And it has also been shown, and see, whenever they produce these enzymes, these bugs, so it is not only OXA48, along with this, they produce other enzymes also. So I'm sure many of you have heard of NDM, New Delhi Methyl-beta-lactamases, VIM and ESBL. So there is a concomitant production of OXA48 with these other sort of a genes which induce resistance into an organism. So this is a very good study, which I'm sure most trainees should remember. It's an informed study which came in 2018 by the US group, where they have tried to look at all various enzyme production by these organisms, by these enterobacteria. As you see, the predominant enzyme produced by 71.3% of enterobacteria or OXA48 along with ESBL or OSBL. So OSBL is ordinary spectrum beta-lactamase, ESBL is extended spectrum beta-lactamase. So 71.3% was a combination of OXA48 with ESBL, and there were all others which constituted different percentage of enzyme inducers. So now what we are interested is Indian data. So there is good Indian data. So in 2006-8, they looked at 39 CREs. These are all lab studies where they found 10 patients had OXA48. So this was a study that came from Pune in 2012, where they looked at 45 E. coli sort of samples, which were carbapenemase resistant enterobacteria. So where they found OXA48 along with NDM, they both occurred together in 55%. So this is a good study from CMC Vellore, where they just appreciate the difference in South India, which is CMC Vellore is in South India. So NDM was present predominantly in E. coli than Klebsiella, and OXA48 was present more in Klebsiella. But when you look at Benares, and NDM and OXA48 was present in 15%. But when you look at BHU data, it was the opposite. So NDM was present more in Kleb, but in Vellore study, NDM was present more in E. coli. In the Vellore study, OXA48 was present more in Kleb, but in BHU study, OXA48 was present more in E. coli, and NDM plus OXA was present in the rest of the patients. So this is the sort of Indian data we have. Basically, it tells you that OXA48 coexists with NDM in some section of people, at least around 10 to 15%. Why this is important? Because when you are talking about the drug Ceftazidime-avibactam, because if you have an NDM variant, because it is not effective, that's why you need to add astronam. So that is the whole reason we are talking about the genes. So now you understand why it is important. We need to know whether if it's only OXA48, then only one antibiotic is enough. So, but if you have OXA48 with NDM, then which is type B, I'll show you the classes, then your Ceftazidime-avibactam also is ineffective, then you have to add astronam. So that is the whole reason for our understanding. And so then they have done this CARBA-R assay. I'm sure some of the labs, like our lab, had CARBA-R assay. So this was one study which showed CARBA-R's ability to pick up resistant bugs. And the median turnaround time, as you see, was 30 hours as compared to a disk sensitivity test, which took 74 hours. And in this particular study, where they used CARBA-R to identify resistance, OXA48 was determined in 50%, NDM was determined in 32.7%, and OXA plus NDM was found in 15%. So the rough sort of a ballpark you can keep in mind is predominantly it's OXA48, which contributes to the resistance in enterobacteria, and certain percentage will have NDM coexisting with OXA48. You could put that around maybe 10 to 15%, at least from all the data that we have been seeing from informed study to the Indian studies. So now we'll talk about this drug avibactam, which we are here to discuss. So this is a beta-lactamase inhibitor. So it is actually beta-lactamase inhibitor because it does not have a beta-lactam ring. So it has something called azobicyclooctane. So basically it acts like beta-lactamase inhibitor by inhibiting beta-lactamase by acetylation and irreversible inactivation. So as I said, avibactam does not have this beta-lactam ring. Rather, it has this diazobicyclooctane, which does not get hydrolyzed by the enzyme. And it is an extended spectrum beta-lactamase inhibitor, and its inhibition is reversible. So these are some of the characteristics of this avibactam. So what is important for the audience is this one. This slide is very important because this avibactam, what we are talking, is active against class A, class C, class D. So for all the trainees, you can remember it is effective against all these enzymes which belong to class A. And the common class A, you can remember, is KPC is what we commonly see. Class C, we see commonly AMC, and class D is OXA-A. But it is not effective against class B, which is NDM, VIM, IMP, and whatever you see. So this is very important when you get a report from molecular diagnostics. If molecular diagnostics come to you, say that it has NDM with OXA48, then you cannot use only Ceftazidime-avibactam. You have to add astronam, or you have to think of colistin or polymyxin or anything of that sort. Okay, so that is the reason. So now what are the therapeutic indications of this molecule Ceftazidime-avibactam? So it has shown to have good epithelial lining fluid concentration. So it is shown to be good for hospital-acquired pneumonia or ventilator-associated pneumonia caused by CRE organisms. It is found to be good for all intra-abdominal infections and urinary tract infections. And it is good against all ESBL producing enterobacteria except class B. So it is effective against class A, class C, class D. And OXA48, it is very good. And KPC, which is class A, it is very good. And Pseudomonas class A and class C also, it is good. And the limitations of this Ceftazidime-avibactam is it is not effective against Acinetobacter. It's just the morphological appearance of these bugs I put. And it is not effective against Burkholderia, or it is not effective against MRSA or Xenostrophomonas or any of these NDM, BIM or efflux pumps. So these are some of the limitations. I think one important thing for all the audience present is it is not effective against Acinetobacter, which is also a problematic bug in our ICU. And it is not effective against Xenostrophomonas, which is also we see it quite often. And MRSA obviously it does not cover. And NDM bugs or any NDM enzyme producers, it's not effective. And it is not effective against anaerobes also. That's how anaerobes look. Okay, now what is the dosage of this? So for all the complicated intra-abdominal infections, complicated UTI or hospital-acquired VAP, the dosage is very simple. It is 2 grams of ceftazidime and 0.5 grams of avibactam. So 2.5 grams is what is given 8-hourly as an infusion for 2 hours. Like any other antibiotic, you would give it for a week, or maybe a bit longer if you have issues with source control and so on and so forth. So that's about, in brief, about the molecule Ceftazidime-avibactam. So it is good against A, C, D classes of CRE, but not effective against B class. And it is good for lung because epithelial lining fluid concentration is found to be good. Intra-abdominal infections is good, and urinary tract infections, it is good. And it is not good against Acinetobacter. It has no effect. Anaerobes, it has no effect, and all those bugs I showed. So now the question is, how did it perform in all the trials? So we have good number of trials. We have RCTs, prospective cohort studies, and observational studies. So this was a good study that came in Lancet. So it's a prospective multicentric randomized controlled trial, including 333 patients done by UK and US group. So 1:1 randomization where they used 2.5 grams of Ceftazidime-avibactam with metronidazole for complicated intra-abdominal infections. And this they compared with best antibiotic therapy or best available therapy that clinicians felt was appropriate. And this was used in patients more than 18 years with complicated intra-abdominal infections or complicated UTI. And end of therapy was within 24 hours of last IV infusion. So they had 2 follow-up periods. The first follow-up was 7 to 10 days after last infusion. And they called something as time of cure or the test of cure, where they took it as 21 to 25 days after randomization, which means they wanted to follow up the patients up to 4 weeks and see whether the recovery did happen. And they called it as test of recovery in this study. And in the best available therapy or the best antibiotic therapy in the control group, 97% of them received carbapenem. So which means Ceftazidime-avibactam was compared with the control group, which got predominantly carbapenems. So this is the response. So Ceftazidime-avibactam, 80 to 92% was the clinical response compared to the best appropriate therapy in the control group, which was 55 to 94%. And as you see, the microbiological response rate also was better in Ceftazidime, 80 to 82% compared to 55 to 64% in the best available therapy or the best antibiotic therapy in the control group. So it mainly had intra-abdominal infections and UTI in this particular study. It's called a REPRISE study. Then there was another study which came called the REPROVE study. This came from the French group and the Spanish group. Again, a prospective multicentric randomized controlled trial. Much larger group of patients, 817 patients. Again, the same dose, but this was compared directly with meropenem, 1 gram 8-hourly. And this was mainly used for hospital-acquired pneumonia or ventilator-associated pneumonia. End of therapy was within 24 hours of last admission. And the test of the time of cure, like the previous one, they took 21 to 25 days after randomization. It means they followed up the patients up to 4 weeks to see whether full recovery happened. And what this study showed was that Ceftazidime-avibactam was non-inferior to meropenem. So it was not superior. So as you see, this is the population. So you see the ceftazidime group and the meropenem group. The orange one is ceftazidime, the yellow one is the meropenem. So there is no sort of a difference. So it was a non-inferior to meropenem in that particular study. And they looked at the resistant pattern. So the 2 patients in Ceftazidime-avibactam were non-susceptible to Klebsiella, 5 in meropenem. So this is just the difference of patients who are not sensitive to these bugs. So that's about the 2 good randomized controlled trials. So one is Reprise study, which showed little superiority of Ceftazidime-avibactam when compared to best available therapy where they use carbapenems. Then the Reprove study for hospital-acquired pneumonia or ventilatory, it was shown to be non-inferior. So these are the other studies where they looked at, this study came in 2017, where they looked at mortality in Klebsiella pneumonia, where they used Ceftazidime-avibactam. So here the meropenem resistance was considered if MIC was more than 16. They took 108 patients, 46% were intra-abdominal, 13 were respiratory, 13 were UTI. And this is the success rate when they compared. So the first column you see is Ceftazidime-avibactam, where the success rate was 85%. And this is the carbapenems with aminoglycosides, 48%, carbapenem with colistin, 40%, and others 37%. And so it showed statistical significance in the success rate, which showed to be better with the Ceftazidime-avibactam in these infections as compared to carbapenem combined with aminoglycosides or colistin. Then this is a good study that came in clinical infectious disease in 2018 called Crackle study, where they compared head-on with colistin, because we know CRE you wouldn't use carbapenem. That's why in the previous studies they've used carbapenem in combination with aminoglycosides or in combination with colistin. So here this Crackle study compared head-on with the colistin-based regime. So this study took 137 patients, 38 in Ceftazidime-avibactam and 99 in the colistin. They compared. And monotherapy was used in 37% of ceftazidime, colistin 6%. As you see, AKI you would expect was significantly less in Ceftazidime-avibactam. But what they found is 30-day mortality, this is inverse proportional therapy weighted, was significantly less in Ceftazidime-avibactam as compared to the colistin. And a better outcome was found in this Ceftazidime-avibactam group. So this was a direct comparison with colistin. But here they use combination. As you see, monotherapy was used only in 37% and monotherapy of colistin was used only in 6% of the cases. So that was a Crackle study which showed that it appeared to be superior to colistin when treated with, when compared with Ceftazidime-avibactam. So this was the sort of a data in hematological malignancies, because these are notorious sort of a situations where multiple antibiotics would have used. So if you look at this oncology settings, all hematological malignancies, this data came from the Spanish group. As you see, there also they have problem with Klebsiella pneumonia. 75% of them had Klebsiella pneumonia, and they have done the genetic sort of a variants. And OXA48 even in Spain looks more. As you see, 62.5% were OXA48, and the rest of it was KPC producers. And the combination, ceftazidime was used with these combinations, aminoglycosides in 7, carbapenems. So which means to say, in this particular hematological patients where you have a difficult to treat infections, they use ceftazidime in combination with these other antibiotics. And this is the cure rate or the survival when compared with the others. As you see, the clinical cure rate was better with ceftazidime. The blue one is the Ceftazidime-avibactam, and the orange one is the other antibiotics. But the survival, there was no difference. As you see, statistically, there was no significance when they looked at the survival rates, but the clinical cure rate appeared better. So this is the data from Spanish group in hematological malignancy. So this was another study which again came from the Spanish group, prospective observational study in 57 patients with intra-abdominal infections, respiratory UTI. Here they compared monotherapy of Ceftazidime-avibactam with combination therapy. So they used monotherapy in 46 patients and 11 patients they used combination. Basically, this study showed no difference in 30-day mortality, clinical cure rate, there was no difference, and microbiological cure rate, no difference. Basically, this study is to emphasize that monotherapy of Ceftazidime-avibactam was good enough and it did not need combination, because the hematological malignancy they used in combination in most of the patients. Here it basically re-emphasizes that single therapy may be good enough and we don't need to do combination therapy when you're using Ceftazidime-avibactam. And here they looked at even all these other secondary endpoints, 14-day mortality, 30-day mortality, 90-day. As you see, statistically, if you look at the p-value, there was no difference between monotherapy and the combination. So to re-emphasize that monotherapy with Ceftazidime-avibactam is good enough and we don't need to combine with other antibiotics. So this was another Italian study, which was a retrospective study of 138, where they looked at KPC producing Klebsiella. And as you see, this is the survival with ceftazidime. The dark line, the faded line is with the non-ceftazidime-avibactam. And this is the survival. The second graph is the survival was found to be better in ceftazidime-avibactam group as compared to the other group. And here in this particular study, they looked at indicators of poor survival in the patients with KPC producing Klebsiella. So anyone who had who are mechanically ventilated had a poor outcome, who had neutropenia, septic shock, all of them were the independent predictors of poor outcome in these patients who have KPC producing CREs. So, okay, so now coming to the last bit of the talk, as to why we use Astronam for NDM, because NDMs is metallo-beta lactamases, so which are impervious to these beta-lactam rings and they get hydrolyzed. So, and adding Astronam has shown to be effective against the NDM producers or the class B producers. Class B is the NDM or VIM or PER. So those are the enzymes produced on which ceftazidime-avibactam is not effective. So these are some of the studies again come from Spain and mainly looking at hematological malignancy. If you see, this is a liver transplant patients where they have already used meropenem with tigecycline, and then patients have become infective. So there they have used Astronam along with ceftazidime-avibactam. Astronam dose they have used variably at 1 gram 8th hourly or 3 grams stat, and they found success rate in all these patients. So this is all the oncology patients they have looked at. So where previously they had failed therapy with different antibiotics. Here, previously the patient had failed therapy with colistin, where they use ceftazidime with Astronam. This is for class B producers. So they've given 3 grams Astronam with 2.5 grams of ceftazidime. And this is a renal patient. Again, colistin was used before. And most of these, as you see, are all complicated patients where they have failed therapy with previously, where they've added Astronam with ceftazidime for class B producers. And all the patients, they had a clinical good success rate. So basically goes on to show that if you have a class B producers, adding Astronam is equally good enough to have a good success rate for these patients. So what are the now pros or advantages of using ceftazidime? So it has a predictable pharmacokinetics and is found to be very safe drug. And most importantly, it inhibits all these enzymes. So it is effective against ESBL producers, AMC, KPC, and OXA48. So remember, it is not effective only against class B. Class A, class C, class D, it is effective. And it is good drug for drug because it has a good sort of a distribution in the lung and it attains good epithelial fluid lining levels. And it has an enhanced activity against Pseudomonas and all the Enterobacteria species. And it could be considered for empirical or targeted therapy. Limitations is it is not effective against class B. It is not effective against Acinetobacter, not effective against anaerobes, and it cannot be used where there is beta-lactam allergy. And you don't need combination for this because we saw the data which shows that you don't need a combination because as a monotherapy, it was as good as combination in the study that we just saw. And mainly reserved for targeted, whether you use it empiric. So that is the question we have. Where would we use empiric? So empiric is somewhere where you have your microbiological data, you have resistance patterns within your ICU telling you that more than 50% are sort of a have a CRE sort of an organism. So these are sort of situations where you may have to consider where you have a high index of suspicion of having CRE bugs. So these are some of the flow charts that you can remember, which tries to guide you where you may have to consider as an empiric therapy. Suppose you have a septic shock patient who comes to ICU with any of these urinary tract infections, intra-abdominal, nosocomial, or any of these. That is not good enough to start empiric. But if you have a septic patients with any of these, with these comorbidities, okay, even then it's not something which compels us to use. But if you have a patient who tells you that they are at a risk for carbapenemase organisms, which means a dialysis patient or someone with a PICC line sitting in, or someone who has been coming into hospital in last 3 months, he's had admissions in the ICU, or who has been exposed to cephalosporins or multiple antibiotics in the recent past in last 3 months, or you have a data from this patient who was infected already with a CRE bug. Then, so if you have this sort of a spectrum where you had a lot of comorbidities, and this box becomes very important, where they are immunosuppressed, where they've had ICU admissions, multiple antibiotics in the past, or who have invasive line sitting, then one could possibly consider using as an empiric choice if they tick all these boxes. Or if you don't have any of this, but your local epidemiological data, this is very important, where local epidemiology data says that your CRE bugs are more than 20% in all the enterobacteria. So you have E. coli, you have Pseudomonas, you have Klebsiella, where CRE is found to be present more than 20% from your lab data, or you have ESBL producing enterobacteria more than 20%, and your Klebsiella is a predominant organism, because once you have Klebsiella, 50% are resistant to carbapenem, then you are possibly justified in considering empiric therapy. Obviously, after obtaining adequate microbiological culture, and most importantly, after sending for rapid diagnostics to confirm, and then de-escalate later when your sort of a PCR test tell you that there is no resistance in these organisms. So this is one of the flow charts that possibly you could keep in back of mind. Then there is this another interesting algorithms that came from Italian group, Bassetti. So he was the guy who I think came to India once and gave a talk on this. So again, so this is just another flow chart to help. So you can send the cultures, and obviously you have to do look at any MDR colonization that patient may have had. And then you look at rapid diagnostics to see whether it's a ESBL, CRE, Pseudomonas, or Acinetobacter. So if it is ESBL, then you could possibly stick to your carbapenems because they may be sensitive to carbapenems. But if you have CRE, carbapenem resistant enterobacteria, then you could obviously consider Ceftazidime-Avibactam, or the other choices are colistin, phosphomycin. And the option 2 is Meropenem-Avibactam, which is still not available in India, or Imipenem-Relibactam. So these are the combinations. Option 3, if you do not have any of these, then you have to stick to your colistin with Meropenem or with other combinations. If it is Pseudomonas, again, these are the choices you have. And if it is Acinetobacter, then obviously your Ceftazidime-Avibactam is out. Then you have Meropenem or colistin as a choice. So this is another flowchart to just try to guide you as to what are the choices that you have when you have a CRE. I think the box you can focus is on this second box, which is CRE. And those are the options you have. You don't have any more options for CRE, either colistin, polymyxin, phosphomycin in combination with carbapenem, or Ceftazidime-Avibactam with Astronam if it is class B. So the summary, that is the last slide. So Ceftazidime-Avibactam is effective against all the enterobacteria which are ESBL producer, AMC or KPC. So KPC is class A and AMC is class C, and class D is OXA48 and ESBL producers. And it is effective against MDR Pseudomonas. And most important is to identify patients who are at risk based out of your epidemiological data that comes out of your own ICU and hospital. And early detection of these resistant organisms goes a long way in saving patient. Most importantly, not to forget all the infection control practices, hand washing that needs to be adopted to mitigate and prevent the spread of these MDR infections. So thank you very much. So I will possibly me and Farooq will take questions after his case presentation, isn't it?